Welcome to our latest Public Health Conversation Starter. My name is Sandro Galea. I have the privilege of serving as Dean of School of Public Health at Boston University. These starters are a series of discussions we have with thinkers who provide a critical perspective on the work of public health. Today, I have the great privilege of speaking with Budi Gunadi Sadikin, Indonesia's health minister, a role he was appointed to in 2020. As health minister, he led the country's COVID-19 vaccination program and has worked to support and strengthen health systems in Indonesia. Prior to his service as health minister, he led Indonesia's National Economic Recovery and Transformation Task Force. And during the G20 presidency of Indonesia in 2022, he helped create the Pandemic Fund, which provides multi-year grants to help low and middle-income countries prepare for future pandemics. I'm really delighted to be speaking with him today. Mr. Minister, welcome.
Thank you.
So
Sandro.
you took over as health minister in 2020.
December 23rd.
An inauspicious year to take over as Minister of Health of any
Yes.
country anywhere. Can you tell us a little bit about COVID in Indonesia and how the country responded and how you felt you did during and emerging from the crisis?
I was asked that by the president to replace the previous Minister of Health. So I only have 3 years and 9 months. And he only asked me to do two things. One is to take care of the pandemic, do the vaccinations, and number two, to do the biggest ever reform in Indonesian healthcare system.
That's a small portfolio. So tell us how those two went.
So 1 year and 6 months concentrate on COVID-19, do the vaccinations, access vaccine, and we can deliver like 2 million jabs a day. So we finished 204 million Indonesian people got the vaccination in 1 year, 6 months. And after that, just concentrate on the reform.
So tell us, let's start with the COVID part.
Yeah.
So what were your biggest challenges in getting the vaccination to where you wanted it to go?
Nobody trusts Indonesian can pay. So I
okay.
approached all the companies and they are quite capitalistic. And so I went to China. I got the vaccine first, but after that, then AstraZeneca approached me because they understand, Indonesia is willing to pay. And then we get from AstraZeneca, when we get from AstraZeneca and the other vaccine company approaching us. But after that, I moved to Gavi. I realized there is an organization called Gavi. So I approached Gavi. So we get around 1 billion, equivalent of vaccine.
Now you said the trust. Was the trust a problem with the vaccine, or was it a problem with the system of vaccinating?
The provider of the vaccine, they prioritize based on the country that can pay. So that is what's happening. So country like Singapore in my region got the access to vaccination first.
Right.
So that is something that triggered me. I think this is scientifically wrong and ethically wrong, if you give the vaccine only to a group of countries that can pay. Because, you cannot stop the virus to spread across the world.
But tell me a little bit, we'll get to that in a second, but tell me about how the population of Indonesia and their trust in the vaccination campaign, how was that?
Not as bad as developed country.
Okay, interesting.
But
and why is that?
I think they are not as exposed as other developed countries' populations about the negative side of the vaccine. But some of them believe that by their religion, that actually they can ask God to cure the sickness instead of using vaccine. So that is the most difficult part.
What percent of the population did you get to vaccination?
204 million out of 280. But the children, we don't vaccinate.
Right, for adults. For adults, it must have been
92, 93%.
Interesting.
And 17,000 islands, by the way.
And
17,000 islands.
17,000.
So that makes it more difficult.
That makes it challenging, yeah.
Yes.
Tell me about, let's talk a little bit about this whole issue of vaccines being available to all countries equitably. Tell me about the Pandemic Fund and how that would work and how it would go towards solving some of this.
When we have this problem, I realized that there are two things. First, the poor country, they don't have money. When they don't have money, they cannot access good vaccine. So that's why we have to create a fund to help them. And at that time, to realize the fund takes 6 months to 12 months. To actually realizing it, it's too late already. But second, again, the fund is available is following the regular path. I work as a banker for 30 years. So I know all the large, development funding agency, they use to work in the peacetime. So the approval, the risk management, it will take months. But this event, you need to work in wartime. So you need the funding to be disbursed in weeks instead of months. So that is something that we need to change. Like in finance sector, World Bank will disburse the loan in months. IMF can disburse the loan in weeks. In healthcare sector, we don't have that mechanism. Everything is by month. So we need to work like in global health architecture, work like in global finance architecture. You have financial crisis, they can jump in a week. So here in healthcare sector, we don't have that capacity. That's why we developed pandemic.
And how do you feel about the pandemic fund? Do you feel, what's your level of confidence that it's going to work the way you want it to work?
It started, it's pretty good. And during the Indonesian presidency, we established first time the joint task force between Ministry of Health and Ministry of Finance. So very, very important. Ministry of Health is the only ministry that have the formal relationship with Ministry of Finance at the global level. Every other ministry don't have it. Ministry of Energy, Trade, Industry, so they envy us. That is a good thing. Now, what we need to improve is still the pandemic fund is very focused on the peacetime process. We need to be able and be ready for the wartime capabilities. So when the pandemic hits, next week, I don't think we are as good as what we aspire.
As good as we aspire. One more question about the pandemic, then I want to move to health systems. 17,000 islands. So tell me a little bit about the logistics of getting vaccination at the same time to so many people in so many islands.
My first 3 months is catastrophic because Indonesia, the last 20 years, that changed like the US, we federalized the country. So that is very difficult when distribute to the governor. The governor has political, associations. Right. So he will not, distribute the vaccine to the mayors, that is not aligned with his political aspiration. So after 3 months, I get back to the president and said, I will not be able to do it unless you help me. How? To mobilize the national police and the national army. Because why? Because it's centralized command and control. So then in Indonesia, the army and the police, they have officers down until the village level, 85,000 villages. We put the Indonesian army and police there. So that is one of the reasons why it works. When we started doing it, I'm not popular globally because, why use this? Why don't you use the healthcare system? Because our healthcare system will not support us to execute at the speed as efficient as the army and police.
Did the use the army and the police affect trust?
Not at all regions, but Indonesia, especially the army, they trust the army.
They trust the army
more than the police.
Let me switch to health systems. So let's talk about the second part of your remit. So tell us how that worked. What you started with, and what you have tried to do in the health system reform you brought about in Indonesia.
What I realized when I joined this ministry and asked by the president to reform, because I'm not a medical doctor, I realized that the name of the ministry is Ministry of Health. So our job is not about curing sick people. Our job is to keep our people healthy. So that is something that is shared. I mentioned to all of them because all of my predecessors, medical doctors, so they trained by 10 years, 20 years to cure sick people, not to keep people healthy. And I talked to other ministers, all of them, the name is Ministry of Health, not Ministry of Sickness or Ministry of Curing Sickness. So that's why, that is what I'm pushing, the reform in the Indonesian primary care. Indonesian primary care started in 1968, so 10 years before Almata. The president at the time established 10,000 primary healthcare clinics owned by the government at 10,000 districts. So we have 38 provinces, 514 cities, 10,000 districts, 85,000 villages, and 300,000 hamlets. So the president at that time built this. Now I revitalized this system. So I moved on to 300,000 hamlets to do promotive and preventive action to our people. My focus is there. One, revitalizing. Second, we change the focus. Before, only focus for pregnant mothers and babies because our population's mostly on that one. But now we move to all life cycles, adult, and elderly. And number three, we do a massive digitalization, including inviting Elon Musk. Because 17,000 islands, we don't have internet connectivity, right? We change the applications, we don't have the connectivity. So Tony Blair introduced me to Elon. I invited Elon to come to Bali and provide, Starlink connection.
So tell us more about the digital transformation. So what actually are you doing with that?
Like example, we do vaccinations and we record in a book.
Okay.
Because of COVID, we can put it digitally with QR code and send WhatsApp messages. So we work with WhatsApp. Bill Cartwright helped me during the pandemic. So because Indonesia love WhatsApp, they don't use email, but they use WhatsApp. So every time you get vaccinations, all these 25 million children, then we will send the mother the certifications, digital certification, and say, hey, next month you have to come again. So that's one invention. The other one that we do is not only immunization, but also screening. We do, like example, infectious disease screening, like malaria, tuberculosis, HIV. We do the screening, put it in our system, and send WhatsApp messages to the individuals, to the family, and to the healthcare workers around the community, so they can take care of the person. The same as non-infectious diseases. We have a blood tension problem and sugar, diabetes problem, increasing very fast. So we do the screening. When their HbA1c is above 5.7, we will send a WhatsApp to the family, because usually men have this problem because we love sugar. We eat a lot of sugar. We send it to the wife. The wife is the only person in the household that is being afraid by anyone. So even the husband will very afraid. Indonesian husband very afraid of their wife. So they will follow, reduce the food intake for the husband, and then send it to community workers so they can come and give whatever metformin or whatever free medicine.
So people are getting this through WhatsApp. So using WhatsApp as the platform to actually get
screening goes to the centralized databases, and then we can monitor which region, which village also have a high prevalence.
What penetrance do you have? Like what percent of the population are you reaching?
We are very lucky during COVID. We use these apps as PCR test result, and then you do it. Then we will give you a sign, the red, green, or yellow. If your red is positive, you cannot go to public locations or public places or public transportation. We use it. Downloaded 120 million by Indonesian people. So then after COVID, we use this as a citizen health apps because we already having it. So all data will be coming in there. And part of the reform that I did, I changed the law. So there is 11 outdated healthcare law combined into one, and put a massive digitalization, and one of them is an opt-out clause. It's different with developed country. So the default data is in. You want to get out, you sign the paper, you get out. But the default is in. So the government have the data.
Let me switch to primary care reform as part of the health system transformation. Tell us about that. So tell us what you actually did with that and how successful you think it was, or what actually remains to be done.
It just started. But primary care, in my view, what's very important is to educate the people. So promotions. What we did, we have 300,000 hamlet, and each of them have 5 community workers, so 1.5 million cadre. Before, they only do pregnant mothers and baby. So we retrain them so they can go to every household and educate the people, either pregnant mothers, baby, children, adults,
so you're expanding
and
the
elders.
scope. So you're expanding
the scope.
Yeah.
And number 2, we realize also why in Japan they have one of the highest life expectancy, because they educate children. So we develop a curriculum for 4 to 5 years old, 5 to 6, 6 to 7, 7 to 8, 8 to 9, and put it digitally, YouTube, everything. Work with the Minister of Education, so we educate them about health early. So that is the promotive activities. One thing that I haven't done, which is my dream. Again, in Indonesia, the mothers are very passionate to take care of the health of the family. We have 120 million mothers. So if we can teach Indonesian mothers, now they can only do things. If you have fever, they know how to use the temperature to the children or husband and give a prescription. You have cough and you have diarrhea. Now I want to teach 120 million Indonesian mothers how to do hypertension, blood sugar, and also cholesterol. And tell their husband to behave well, stop smoking, and then send them to the primary healthcare clinics, because we provide free amlodipine, free metformin, or free statin for them. So that is, I haven't done yet, but I work with somebody there is an NGO in US. I said, I want to train Indonesian mothers.
That's the aspiration.
The free healthcare providers.
So you speak like a health thinker. You talk about prevention.
Yeah.
You understand the difference
I'm a
between health
nuclear
and sickness.
physicist, by the way.
But you're a nuclear physicist, and you, before
Bank-
this had a career in banking.
Banking at 30
So
years.
tell us about your personal path. Tell us how somebody with nuclear physics background and banking comes to be a minister of health who understands health so well.
So I got the challenge by all these doctors when I became Minister of Health. You don't understand, you don't have the background. My argument to them, hey, you have to remember the first Nobel Prize winner, medicine and physics. In 1931, the first Nobel Prize winner in physics is William Ronson. And his invention is being used up until now. Millions of doctors and hospitals. And the third, Nobel Prize winner in physics is Jean and Pierre and Marie Curie, which is the technology is used in radiotherapy by all hospitals and all doctors. So if you believe that physicists don't have any contributions to medicine, I think you're totally wrong. That is my argument.
That's a fair argument. But tell us about your own journey. Tell us what your path was.
I know. Working as the CEO of the largest bank in the country, your income is like this. Working in the minister in the country, like in the income is like this. So people asking me why you do it.
Yes.
It's because the best wealth is health. I've been giving billions to my client, raising money. Although it's not trillion US in 30 years, but I feel so much contributions to the wealth of my clients, but so little contribution to humanity. Here, I help like my friends. Peter San used to be the CEO of Standard Chartered Global, now is CEO of Global Fund. Only raised like 16 billion, which is for us bankers very, very small, 30 years, but it saved 50 million lives, HIV, tuberculosis. So you raise actually a very small amount of money, but you feel so much contribution to humanity. That makes me, love to work in healthcare sector.
Let me switch to hospitals for a second, and clinical care in Indonesia. So tell us a little bit about the system of clinical care in Indonesia, how primary care links to secondary care, links to tertiary care, and the balance between prevention, primary care, and tertiary care, sickness care.
Before, again, because all of the previous health ministers as doctor, which is trained 10 years, 20 years to cure sick people, but not to keep people healthy. The budget, the time is spent by the health ministry more to the secondary care. But now I changed that to 50-50. But I can share also with you our coverage financially, the National Health Insurance, we only have one. 220 million members, which is very, very good already to solve the demand side. The problem is with the supply side. You have 3,200 hospitals, but I give you an example. The number one killer is heart attack. Number two is stroke. If you get heart attack and stroke, somebody told me, Budi, you need to have a device called the cath labs, because in less than 4.5 hours, you need to bring this patient to the hospital and insert a ring or thrombectomy and coiling if you have a stroke. Out of 514 cities, we only have 44. Out of 34 state or region provinces, we only have 28. So we still don't have this facility. People are dying. I give you another example. Number one killer in women is breast cancer. Breast cancer, what I learned, if you identify early, detect early, actually with current technology, 90% probability to survive. But you detect late, then 90% fatality. So what we did, you need to do mammography to detect. Out of 3,200 hospitals, I only have 200 hospitals have mammograms. So can you imagine the access to this facility is ridiculous. So that's why I come to World Bank and just approved last December a $4 billion loan. World Bank, AIB, ADB, Asian Development Bank, and ISDB to revamp our primary care and also hospitals. So we buy like cath lab for 540 cities, mammogram 440 cities, chemotherapy facilities 440 cities, CT scan 540 cities, LINAC, radiotherapy in 34 provinces. But then I hit another problem, which is availability of doctors.
Interesting. How bad is that problem? How many doctors are you missing?
I Googled. This is all the doctor association attacked me in the country because I said we don't have enough doctor. Budi, you don't understand. We have enough doctor. The problem is distribution. Hey, when I Google, the average lower income country is 1 for every 1,000. 280 million. I need 280 million doctors. I only have 140, so 0.5. And when I see the rank globally, same as Yemen and Tonga. Even East Timor, Philippines, is above us. So I need to produce more. And at the time when I came, there is a moratorium in the Faculty of Medicine establishment. We only produce 12,000 per year. We have 140,000. We need 280,000 to reach a lower middle income country average. Global average tendency 1.76. So I need another 200, 300,000 doctors with the average graduate only 12,000. And they said, that's enough. So I said, I don't understand. And somebody told me, oh, they love to control the supply side. Right. So the price is high. And so that's why I'm pushing the reform and opening more faculty of medicine and specialty education. At least I've successfully done it in the specialist education. Before, special education in Indonesia, in the only country in the world, it's run by the university, specialists. Right. Here it's run by the hospital.
I want to ask you some global questions, but before I do that, one more question about your term as Minister of Health. What has been the hardest challenge you've actually dealt with?
With the medical professionals.
With the medical professionals? Based on this issue of supply and...
Based on the issue of supply. And they are very close. Like, I give you an example. We don't have enough doctors. Most of our rich patients and some of the middle class goes to Malaysia, Singapore, and Thailand.
Right.
Because of the quality. But every time I want to bring a foreign doctor, for example, from Mayo Clinic, Harvard Medical School, they are not allowed by the association. But that is one of my topics.
It is interesting that as a Minister of Health of such a large country, in this moment in time, you note your biggest challenges with the medical profession. That's an interesting observation. Let's talk globally for a second. Let's talk about from your perch. What do you see as the biggest challenge that sort of middle low income countries face right now globally around health?
They have two sides. Some of the lower middle income countries have a problem on the demand side. So they don't have enough financing to make sure that people have access. But some of the middle income countries, especially upper middle income countries, have a problem on supply side. So they cannot supply the quality healthcare services, with a good price. So lower middle income countries, in my view, have a demand side problem. They don't have enough, power to let these people access because they don't have enough funding. But on the middle income country, upper middle income country like Indonesia, we have problem on the supply side. We don't have enough facilities and enough healthcare professionals to serve standard quality and a good price. But price is everywhere. When I see the health cost per capita increase in every country except India in the last 20 years, it's more than GDP per capita increase. It's unsustainable. The price to delivering a healthcare cost is extremely high. And it doesn't relate. I give you an example. United States, 79 years old average. You spend like 11,000 per capita health cost. You go to Cuba and Panama, the same 79, you only spend 1,900.
What do you spend?
Huh?
What do you spend?
140 US for 72. Malaysia, 76, 430, 300 US more. So I talked to the Minister of Finance. If the next 5 years we go to Malaysia, our average life, I'm 60 this year, so I hope I can live 76. And then 300 US multiplied by 280 million, 84 billion US. If we go to Singapore, the most efficient country, 84 years average, 3,300, 3,000 US more than Indonesia, we go to that level, we spend 3,000 multiplied by 280 million, 840 billion US. Very expensive, very expensive.
That's an interesting difference between the lower middle income versus higher middle income. That's an interesting distinction. Let me switch for a second. So in G20, when Indonesia was the president of G20, you actually proposed the joint finance and health ministers meeting, which, as far as I know, is the first time such a meeting happened. Tell us a little bit about that. Tell us a little bit about how that went.
Because when the pandemic happened, two things that I realized. I've seen many financial crises. When financial crisis happen, there is an single institution called the IMF that can jump in weeks, to inject money solve the financial crisis issue at the balance sheet of any country. In healthcare sector, when you have a global crisis, global health crisis, not global financial crisis, it's so fragmented, the organizations, and they are not ready with the money. WHO only give you advice. Advice, you cannot do anything. We need money to bring in the vaccinations. The difference with finance, money is not here. Indonesia has money. We cannot access the vaccine because it is not available. So we have to provide emergency medical countermeasures like the vaccine, therapeutics, and diagnostic tool, and change that to public goods during pandemic only. If it is controlled like a private goods, people will die. And it scientifically wrong and ethically also wrong if you can only save one country. Because, these 8 billion people move around the world. So that is something that I said in Bretton Woods, California in 1944, the aftermath of World War II, developed countries sit together and establish these two great organizations, IMF and World Bank, as the main pillar of a global financial architecture. Now that is the time that we sit together again during the pandemic in Bali in 2022 to establish this pandemic fund that hopefully will play as global health architecture, global health pillar that protect from this pandemic and the future pandemic. Yeah, IMF and World Bank protect the future financial crisis after the World War II. Now that is something that we have to do. And we have to roll up our sleeve and do it, not only talking, just do it.
Let me quote something that you said. You said health, quote, cannot be approached as a program, but as a movement. Tell us a little bit what you mean by that and how you think we achieve such a movement.
During pandemic, I want to do the vaccination. I hit the wall because the speed is only 10,000, 20,000 a day. I need to reach 1 million or 2 million a day. Then I realized, because the approach of my ministry is like exclusive. The ministry stand above the people is exclusive program. It is our program. I said, no, we cannot do this alone. We have to do this together. We cannot do this exclusively. We have to do it inclusively. And we cannot treat this vaccination as a program. We have to make it as a movement. But it's not owned by us. It's owned by the people. Otherwise they die. So that's the approach that I have. I used to lend money to almost everyone in the country. So I knock on the door of all of them and said, hey, I don't have enough capacity to do it. Government, very bureaucratic, very slow. Why don't you help me do vaccinations to your company, to your region, to your cities, I will provide you the vaccine. So that is a successful, initiative, the most successful initiative. Then I realized it's not only for vaccination, but for any healthcare reform. Healthcare is to be owned by you, not owned by me and Minister of Health. If you own your own health issues and want to live healthy, then 50% of my job is done.
You speak like someone who's been steeped in public health all your life. And I mean it as a compliment.
No. I'm retiring in the next month.
Let me talk about universities for a second, because you're on the board of trustees, right, of the Bandung Institute of Technology.
I'm the president now.
So you really have close links to universities. And
yes.
Tell us, how do you see the role of universities in this ecosystem that generates health? There's the ministry, and obviously you've been doing very practical work. Universities are in a different world. So how do you see their role?
University need to create a path in the future, because they sit in the position, they don't have as much pressure as I do in terms of delivering something. So they have some, free time and free place in their brain, to guide us to the future. So that is something that I want my university to be like that. And again, university is like the doctors. My university never has the president or the CEO, and the president and the CEO coming from other university. So they're very close, they're very siloed. They want to the Bandung Institute of Technology alumni to become the CEO. I said, why don't we hire from Harvard Graduate School to become the CEO? So make it open, and then we can improve our ranking. Our ranking is declining. So I feel very sad with the Indonesian universities. I want them to be, more progressive, to create a path, create a future.
And my last question, my hardest one. What gives you hope in this moment?
Every time I see Indonesian young people, I see their eyes. They want to live a much better life. So that gave me energy and hope. I think what if we can do something for this generation to become a better generation than I do, I think that is the most, what to call it, fulfilling jobs that I can see. So I do hope Indonesian people, next generation will be smarter, richer, and healthier than my generation.
That's wonderful. Mr. Minister, thank you. Thank you for what you've done for health in Indonesia and around the world. And thank you for talking to us. It's really a pleasure. Thank you, everybody, for joining us.